Okay, guys, we're going to go ahead and get started. We've got our colleagues in Decatur joining us over here, and we have a very we have a very small crowd in Springfield, so hopefully that will increase as we move forward here. So, guys, welcome back to another part in the quality improvement and patient safety curriculum for graduate medical education. Today we're going to talk about unexplained clinical variation. Anybody have a good appreciation for what this is? Okay, it's actually it's a thing now in the medical literature. You can actually search unexplained clinical variation, and you're going to have quite a bit to read about. And so this is going to be our focus today. I'm going to highlight the areas of variation in medicine. This happens on multiple different levels, and as we move forward here, I'll ask for some examples that you've seen in your own clinical work. We'll talk about what creates that variation, and then I'm going to give you some ways that people have been successful in reducing variation and how that's related to both efficiency and patient safety, things that we're certainly interested in. So protocol, standardization, order sets, good or bad things? Yes. Both. Okay, give me some pros. You guys are going to have to do the heavy lifting today. So what's good about those things? Okay, saves time. Yeah. What else? Okay, if they're designed right, they can be fairly easy to use. Okay. What's bad?
You can order something that doesn't necessarily need to be ordered. That's the line, and that's it.
Okay, okay. So there may be things that you don't necessarily need that are within an order set, and when you're ticking things off, it's pretty easy to maybe get something you don't need. What else? Cons.
Engagement.
Okay, okay. So sometimes the resistance or the criticism is that you take away the need to think or to think critically about your patient. Okay, good, good. And we're going to come back to this idea when we talk about standardization a little bit later. So there are a lot of different ways to have variation in what we do. There's variation in resources, certainly, the way we utilize resources, and the way that we distribute resources. And this has become, highly visible, thinking about the Affordable Care Act and how we're paying closer attention to utilization of resources on a national level. You can talk about variation in processes, and this varies from organization to organization, region to region, and even local culture. There's a lot of variation in the way that we actually carry out processes. For example, where I trained, we did only the primary service on a patient wrote any orders. Okay, consultants didn't write any orders at all. And then I come here, and the local culture is quite different than that, and that consultants can write anything. And I can come in the next day and find that my patient is headed for a procedure that I had no idea about. So that's a significant variation in processes and approaches to patient care. Clinical judgment, okay, this is probably the greatest source of variation. How many times have you worked with one attending and then another to find that they approach a very similar problem in very different ways? Has that happened to anybody? Okay, good. It happens to us all the time. So why do we care about variation? There's actually thought that if we could reduce variation, it's estimated that we could save Medicare about 30% in expenditures, okay, if we could reduce clinical variation. And they have ways to define that, and that's a bit of a moving target. But there is certainly some room for improvements in both safety of patients and efficiency if we could reduce some variation. You guys are probably well acquainted with this. The Organization for Economic Cooperation and Development looks at healthcare spending around the world or of its member organizations, and we spend a lot of money. And so we're way over here on the left-hand side, 18% of GDP in 2010. Does anybody know what the OECD is? When did that start? Any idea? Okay, just a little piece of trivia. This was the organization that was formed to actually implement the Marshall Plan after World War II. Okay, and it was recognized that in order to distribute these economic resources that were sort of being pooled to help rebuild countries after a devastating world war, that there had to be some collaboration and sharing of economic data, okay, among the member countries. And that relationship evolved over years, and they share other markers of economic progress and development and needs. And healthcare is one of those things that they actually track. And so that's where a lot of this data comes from. So we spend a lot more than what would be expected by GDP for per capita. We're way up there at the top in the middle. So healthcare spending per capita, GDP per capita, we're sort of off the chart when we look at other member countries. So that's one thing. Is it okay to spend that much money on healthcare? We know that it's not, right? Because we could potentially bankrupt the country if we continue to do what we're doing. It would be perhaps acceptable if the quality of what we were providing was better, okay? If people had better outcomes, which is what we really care about. Here's some examples of our outcomes. The OECD is average is in red. For breast cancer, our 5-year survival rate is better than average. We're at the top, 89.3%. The colorectal cancer 5-year survival rate, we're just a little bit behind Japan. And this was 2012 data. So that looks pretty good. We're good at that. How about this? Asthma hospital admissions. We're at the very bottom, 120 per 100,000 patients. COPD hospital admissions, 230 per 100,000 patients. We're significantly below average. And look at us compared to Canada. COPD, look at us compared to France at the very top. Some of these countries have much higher smoking rates than we do, okay? But we hospitalize many more patients for COPD and asthma than those countries do. Why is that? Any idea? Okay, other comorbidities. So are our patients potentially sicker than other patients of other industrialized nations?
Culture.
Culture, okay. Okay, maybe we have a lower threshold for doing it. These are what we call ambulatory sensitive conditions, okay? And this is getting a lot of attention now as well, how we handle these conditions. The thinking is that if you manage these patients well as an outpatient in the ambulatory setting, you avoid hospitalizations. So this is actually a marker, or is used as a marker for quality of ambulatory care, okay? So the variation here that we're witnessing is difference in hospitalizations, but probably the root cause of that is how we deliver preventative services, okay, to patients. And we know that other industrialized nations are much better at providing preventative services than we are, okay? The United States is #1 in rescue care. If you're trapped on top of Mount Rainier, and you're having a heart attack, chances are we'll rescue you and save your life, okay? Because we are fantastic at rescue care. If you have 5 healthcare conditions, diabetes, bad heart disease, asthma, in the outpatient setting, we're less likely to rescue you, okay? And part of that is culture and sort of where the importance of medicine's been placed in the country. So significant variations across the world compared to our cohorts. So why do we spend so much? Geography is destiny. Have you guys heard of the Dartmouth Atlas? Okay, I'm going to tell you the story of the Dartmouth Atlas. This is good stuff. There's this guy, Jack Winberg, and he was a young physician, public health person in Vermont in the 1970s. And his child had recurrent tonsillitis and needed a tonsillectomy, so the pediatrician said. And so Jack took his child to see a ear, nose, and throat specialist and said, no, you don't need a tonsillectomy. So he got a second opinion. The second opinion was, yes, you do. Third opinion was, no, you don't. The story goes something like that. And so he started to wonder, why am I getting such different opinions about what seems like a pretty straightforward problem? And so the public health bend in him started looking at tonsillectomy rates. And they were right up here in Vermont. He looked at two different towns, Stowe and Waterbury, and they were about 15 miles apart. And he looked at all of the 15-year-olds. And in Stowe, about 20% of the 15-year-olds had had tonsillectomies. In Waterbury, about 70% of the 15-year-olds had had tonsillectomies. Why is that? And this is what he ended up building his career upon. So why the difference?
Waterbury, someone was getting some type of financial benefit from these tonsillectomies.
Okay, potentially. Do you think that the kids in Waterbury were more sick or had more wicked tonsils than the kids in Stowe? Probably not, yeah. 15-year-olds, 15 miles apart were probably pretty similar. And so he felt like, and he wrote a paper in this that was eventually published in Pediatrics, and it was pretty controversial. What he found was it was a difference in sort of training and local philosophy of the ear, nose, and throat specialists and the pediatricians that were practicing in both of those towns, okay? So he did something interesting. He went to the Vermont Medical Society. He reviewed the data. He said, here's our performance data for tonsillectomies, okay? These are our rates of tonsillectomies in Waterbury and Stowe. He circulated the most up-to-date literature. This is the evidence for doing tonsillectomies. And then what do you think happened to the tonsillectomy rates? It was Waterbury that had the highest rate. Yeah, what do you think their tonsillectomy rate was after this? Okay, 20%. What do you think happened to the tonsillectomy rate in Stowe? It was 20%. Stay the same? Up or down? Okay.
Did they meet in the middle? Did the one go down and one come up?
Okay, so there are potentially two problems, right? Are the physicians in Stowe not doing enough tonsillectomies? Okay. Are the physicians in Waterbury doing too many? They both went down. Okay. They both went down to about 10% after this. So that means even in Stowe, they were doing twice as many tonsillectomies, potentially, as they could be. It's a little bit hard to compare that data over that period of time, okay? But tonsillectomy rates dropped significantly with this potential intervention. So, like I said, this is where he built his career. So what did he do? So at Dartmouth, they created a center for the way that healthcare is delivered and created what was called the Dartmouth Atlas. And basically what they were able to do is mine CMS data, which is Medicare data, Medicare databases, to look for variations in utilization of Medicare dollars and delivery of services. This is disease severity adjusted Medicare claims data, okay? So they tried to make a Medicare beneficiary in Florida look just like a Medicare beneficiary in Illinois, okay? So you can compare them. And they didn't look just at states. What they looked at was they divided patients into referral regions. And those referral regions cross county boundaries, they cross state boundaries. It's really where patients go to get their care, okay? Sort of, there's generally a central hub and then sort of a catchment area, okay? And then other patients go to other referral regions. Springfield is a referral region. And so there were about 300 of those clusters around the country. And what they found were that higher spending areas had significantly more care than lower spending areas, okay? So it was sort of an intensity that was related to the dollars that were spent. So if you lived in a higher spending area per beneficiary, you were more likely to be admitted to the hospital, spend more time in the hospital, have more tests, see more specialists. Overall, 60% more care. 60% more contact was delivered to those beneficiaries. Example, Provo, Utah, when you look at the demographics of their Medicare recipients, they're some of the healthiest people in the country. Okay, some of the healthiest Medicare recipients in the country. They were spending about 7% more than the national average was spending. Okay, Richmond, Virginia is one of the sickest by demographics. They were spending 21% less. So what's the question? Is this okay? Are the patients in Provo healthy because we're spending 7% more for each one of them? Are the patients in Richmond having worse outcomes because we're spending 21% less? The answer is no, okay? Their outcomes were not any better. Have you guys looked at the Dartmouth Atlas? Anybody? Okay. Every year or two, and this has been going on for about 20 years, every year or two there are criticisms of how they analyze their data and how they risk adjust their data, but the message is pretty consistent throughout time, okay? And you know, the controversy that surrounds the Dartmouth Atlas never lasts very long, okay? They're always able to sort of overcome and continue to show that the work that they're doing is fairly important at highlighting clinical variation. And we're going to get to this in just a moment. This was an article, and I apologize, I don't have the reference. Why are ICUs always full? They're always full, right? We make bigger ICUs, we have more beds, they're almost always full. Is that because there were, 10 patients who needed ICUs and now we have 10 more beds and those patients have beds? It's called supply-sensitive care. The more ICU beds we have, the more ICU beds we fill. The more CAT scanners we have, the more CAT scans we do. Okay? This is true in a lot of healthcare. Our resources never sit idly. We use them, okay? And we tend to maximize use of these resources. Miami, if you have knee osteo, 5 times more likely to have arthroscopic surgery than in Iowa City. Okay? Quality of life scores are the same. Functional outcomes, the same. So why are patients in Miami having more arthroscopic knee surgeries than patients in Iowa City? More orthopedic surgeons per capita. Have you guys read anything by Atul Gawande? Nobody? Okay. Great guy. He's a surgeon at Brigham and Women's, affiliated with the Harvard Medical School. He's a prolific writer, and he has a very nice, engaging style. He's written several books, the Checklist Manifesto. He was on the working group that produced the World Health Organization surgical checklist that the surgeons in the room have some experience with. And he also publishes fairly regularly in the New Yorker. And in 2009, he did a piece on 2 towns in Texas, and it looks at variation in clinical spending. So in 2006, the average Medicare cost per patient was about $8,000. And he looked at El Paso and he looked at McAllen. In El Paso, they were spending about $7,000 per beneficiary. And in McAllen, they were spending about $15,000 per Medicare beneficiary. These two towns were not all that different. McAllen, though, had the lowest household income in the United States. But that year was one of the most expensive healthcare spenders in the country. Why do you think that is? Anybody care to guess? Anybody? So if you guys haven't heard of him, you may not have read this article. Okay. They're both border towns, okay? Population's not significantly different. McAllen, more poverty. If you risk adjust those patients for severity, they're pretty similar. So despite the McAllen population having lower household income, medically they were fairly similar, okay? They're both border towns, so they have a high number of immigrants and that were drivers of cost as well. But what they found was that they had a significant amount of money spent. So Atul Gawande went down there and did all of these interviews with people, with physicians, with the owners or the management of these healthcare organizations, multiple hospitals in both towns. The interesting thing is the people who ran the healthcare organizations were not aware of the amount of money that they were spending on patients. Okay, even the physicians in these organizations were not aware of the amount of money that they were spending. And when it all came down to the end, what they found was in McAllen, there had been sort of an explosion of physician-owned and physician-run healthcare organizations, including home health. Okay, a lot of physicians were actually owning part of home health corporations. There was a hospital that had opened in the previous couple of years that was physician-owned. Okay, and a lot of the equipment was bought by these organizations and they were using it. Okay, so supply-sensitive care. They were increasing the supply and they were using a lot of those things. Okay, part of the driver of the cost actually. So the business of medicine, the local culture, as we saw in McAllen, can really lead to extreme costs and overuse of healthcare resources. This article that he wrote was actually required reading in the Clinton administration when he was thinking about how to cap healthcare costs. This was part of that. And Atul Gawande used the Dartmouth Atlas to create a lot of this information. And these pockets of spending and this variation in spending was really getting the government's attention. This is where a lot of that information comes from. So just by sheer volume of exposure, unnecessary care probably makes medical errors more likely to happen. Okay? Sometimes the more you do, the more complications we see. So tell me about your experience with variation. What do you guys see at the local level? Anybody have any examples?
Not at the local level, but I know there was, it's been multiple years ago, but when physicians own the imaging equipment, it's just like you're seeing there, when they own.
Mm-hmm. Yeah, that's very consistent with what we see at the national level for sure. Yep. Any other examples? How about on the medicine side? Examples of variation?
I've seen like in private practice, like in your like private practice, and like they order more tests than what we do in our practice.
Okay.
Order more tests than.
Okay, we have some examples. From both hospitals, we get performance data, and there's significant difference in from the internal medicine side, from the amount of tests that we order and laboratory studies among different groups in town, even, and subspecialist consults. We can see what subspecialists have the most consults, and what groups they belong to and who's referring to them, and yeah, there's significant variation. Okay, so even among individual providers, yeah, we see significant variation locally. Okay, any other comments? Is this information surprising to anybody? No, you kind of know that it happens, right? Okay. Overutilization and underutilization is part of this variation piece. In 2002, we had 40 million CAT scans. 2007, 70 million performed annually. Yeah, that's significant. We underutilize preventative healthcare services, for sure. We know that at a national level compared to other countries, our outcomes are not as good. We hospitalize more people. It's estimated, though, that we're the biggest drivers of variation, okay? That our individual decisions drive 70 to 90% of clinical variation. The nature of clinical judgment is really interesting, and this is really hard to get at, too. There was a study that said that physicians looking at the same thing will disagree with each other and themselves 10 to 50% of the time, okay? So for example, this piece looked at cardiologists looking at the same angiograms, and they repeated them over time. That the cardiologists disagreed with the diagnosis of typical patients about 50% of the time in this particular study. And they disagreed with themselves on 2 successive reads of the same angiogram up to 30% of the time. That's significant variation, okay? And there are so many variables that affect us at any given time, and so many biases that we have that affect our clinical diagnosis skills at any given time. So is this a lack of competence? Or is this truly the art of medicine? Is this the piece that you can't get at because it's what makes us who we are? That there's an art to this that you can't alter. Historically, that's been the thinking. Okay, is that what we do is different than what anybody else does. Okay, medicine for a long time. And still continues to be, and to some degree, has been practiced as a craft, okay, as sort of a skill and an art, that your focus is truly the patient in front of you. It's a one-to-one relationship, and historically, that's the way it worked. We didn't necessarily record processes. We didn't engineer or design processes to deliver care in a standardized way. And we were personally and financially accountable, okay? So we accepted all responsibility for the craft that we were providing. It was us and the patient. And we know that over time that's changed, okay? Healthcare has been industrialized to some degree. We have corporations, and you know this in our own community, and those corporations have expansion goals, okay? They're businesses, non-for-profit. Okay, the goal is to take care of patients, but they're businesses and they have expansion goals and they're competing, okay? They're competing for customers. And so there's a significant change in risk allocation. It's not just myself and the patient. There's an organization that's liable as well, okay? And that organization takes steps to reduce their risk. There's a lot more attention on cost, quality and value. Value is really the combination of quality and cost, okay? It's quality over cost, right? It's an equation, it's a relationship. And that's really the goal, is to maximize quality, minimize cost if we can. But with all of that, we still consider medicine to be a little bit different. And this is an example of how organizations morph over time. And I'll use Dell computers as an example. So, when we first started, people were making computers in their garages. It was a craft, right? They were doing it for themselves. They were doing it for the people around them for very specific needs. It was a craft. Once we became very good at the craft, we could develop processes to deliver that craft, to deliver that product. You can start doing mass production. And once you are able to achieve mass production, then you're able to start linking these processes together and working on particular processes, okay? To the point where you can develop mass customization. And how did Dell do this? How do they mass customize? They were the first company to do this. You don't have to go to the store to buy your computer. You call us and tell us what you want, and we'll make it for you. Okay, so they changed mass production to mass customization. Okay, you ordered your Dell computer with the things that you wanted, not what came on it at the store. Okay, it was customized to you. And then there's an element of co-configuration that's a whole different deal. But the idea here is in the middle, you can modularize part of these processes. Okay, so you don't have to standardize the entire process like you do in mass production. You can standardize pieces of it and then link them together. Okay? So what happens is you don't have an assembly line anymore. What you have are these nodes of standardization, and then you pick the pieces that are relevant to you at any particular time. Okay? That's modularization. That's really the goal in healthcare if you want to reduce variation. Okay? That's a really sort of drawn out way of saying standardize what you can and use pieces of standardization to customize it to the situation that you have. Does that make sense? But that requires us to do a couple of things. We have to consider medicine and healthcare as a system, okay? That it's not just a craft, okay? That we're actually delivering a system of care and we're overseeing a system of care. You have to understand what the best practices are and deliver those. Standardize what you can and nothing more, and consider decision-making assistance, okay? So back to the order sets. There are situations where there are things that you don't need on order sets that make them potentially harmful. So how do you apply an order set to a large population of patients, not just the patient right in front of you? How do you do that? Give me an example of pieces of order sets that work. What's an order set you use commonly? Neurology. Stroke order set all the time. Okay. Do you fill out the entire order set? Okay. So you're selecting the pieces of standardization that work for your patient. Okay. But in terms of managing entire stroke population, that population is more consistently getting what it's needed. Okay. An example of this, I'm going to move forward here, is that we know what to do, okay, but we don't always do it. The prime example is hand washing. Semmelweis, 1846, maternal child bed fever. Up to 40% of women giving birth were suffering complications or death. Why was that? What did he eventually come up with? You guys remember this from medical school? Washing your hands, but why? How did he come to that conclusion? Who had worse death rates, the midwives or the physicians? The physicians, okay? The physicians, because they were doing autopsies and postmortem examinations on their patients, and then bopping over and delivering babies. Okay, they were going back and forth. And you know, this is before germ theory and before we really had an appreciation for that. And the midwives were just delivering babies. Okay, and so there was less contamination of the mother from the postmortem theater with the midwives and the physicians. Okay, so he surmised that physicians had to wash their hands, that people delivering care had to wash their hands. Significant decrease in maternal death during childbirth. Current hand washing rates, highly variable, about 50% among physicians. What group in the hospital washes their hands most consistently? Who? Nurses? Who? Maybe before the OR, but not on the floor. No? No? Housekeeping. Housekeeping. 90, 100% washing their hands in and out of rooms. Food service. They wash their hands more often than we do. We're bad at it. Even though that we know that it saves lives, it's good to do. Aspirin after myocardial infarction, in the early 90s, we were giving it to about 30 to 70% of patients who left the hospital after an MI. We've known that aspirin has been good for people for a very long time. So why didn't we do it? Is it because the internist back in the 90s would say, yeah, they don't need it, they'll be okay? Or the nurse who was discharging the patient said, no aspirin. Why didn't we do it? We forgot. We forget, okay? Thinking about the beta blocker, we're thinking about, you know, the scheduling them for cardiac rehab, we're thinking about their follow-up appointments, we forget the aspirin, okay? Now, it would be almost impossible for me to discharge a patient from the hospital who had an MI without an aspirin. I mean, I would have to try really, really hard to do that. Why is that? We're hitting 99-point-something% nationwide for patients leaving the hospital on aspirin after an acute MI. Both hospitals were about 100%. What made the difference? Are we smarter?
Part of the discharge order set.
Yeah, it's on the order sets. Good, thank you. Good. We took that piece away. We took that piece away that happens for just about everybody, okay, and we took the piece away that was extraordinarily important for the patients. It's probably one of the most important things we do for patients who have had an MI. So there are a lot of reasons why we miss things like this. What we do is complex. There's solid evidence lacking for a lot of the decisions that we make. It's estimated that of the several hundred decisions that we make a day, about 20% of them are based on solid gold standard evidence, what we consider randomized controlled trials. That data is also coming very quickly, okay? To stay on top of that gold standard evidence is becoming increasingly hard. So what we do is complex, and we don't have enough room in our brains. There is this idea of comparative effectiveness research. Anybody involved in anything like this? Okay, we're going to talk about this piece, and then I think we'll wrap it up here in a second. Comparative effectiveness research is really looking at the outcomes that are important to the patient at the bedside. Okay, so for example, if I have a patient that I'm discharging who has had a stroke, I don't necessarily want to know that this statin is better than nothing. Okay, maybe what I want to know is this statin is better than that statin. Okay, or this statin has fewer side effects than that statin. Those studies often are not done. Okay, or I want to know about if this statin is going to increase the patient's longevity. Do I care that it decreases carotid intimal thickness on endocarotid ultrasound at a certain period of time. What I'm really concerned about are outcomes, okay? So a lot of the research that we have on drugs and products are based on surrogate markers that are difficult for us to apply at the bedside, okay? So there's this idea of comparative effectiveness research to help us make better decisions at the bedside. So that's sort of one way to standardize or to help us to decrease clinical variation is to give us really good data at the bedside, okay? That gives us an idea about effectiveness of therapy, not versus no therapy, but effectiveness of therapy versus therapy, okay? And I find myself in those situations often where I'm trying to interpret the literature in a way that's relevant to the patient at the bedside. And so that's one element of decreasing decision-making among physicians. Anybody have any experience with decision-making programs? Decision support systems in prior EHRs? No? Okay, so there are a lot of products emerging to help us make clinical decisions, and those range from looking at sort of services due for a patient. So for example, if I go to my clinic and pull up a patient chart, I would get a report that said this patient is due for these things, okay? It ranges from things like that to something that can be very patient-centered. There are models that exist now or that are being studied now looking at sort of all the comorbidities of the patient, what that patient's potential outcomes are related to those comorbidities to help you sort of risk stratify what to do next for the patient, okay? So if you have diagnoses that lead to sort of competing treatments, which one do you choose first? And there are models that are being developed to help us treat those or to help us make those decisions. In addition, there are also models that are incorporating patient preferences, okay? So if the patient's goal is to maximize, quality of life or to maximize independence, your approach to their overall healthcare might be a little bit different. So there's a lot of interest in developing computerized models like that. It's going to be very interesting. That as a whole will probably help decrease variation within the population itself. So any questions or comments? Okay, so this is a bit of a broad topic. I wanted to give you some exposure to different aspects of variation, both from healthcare spending and resource utilization, sort of at the national level, international level, some variations in healthcare spending and outcomes within the country. And then we talked a little bit about some local variation too. Some ways to improve variation, some standardization of care where we can, particularly for those very high priority outcomes like aspirin after MI, standardization of that help improve our rates significantly. Okay, good. Thank you. Any questions, indicator? Carbondale?